Welcome, everyone, and welcome back to IS-PEC Talks. Today, we're delighted to host Dr. Ross Brownson, one of the leading global voices in evidence-based public health and implementation science. Ross is the Stephen H. and Susan U. Lipstein Distinguished Professor of Public Health at Washington University in St. Louis, where he leads major efforts focused on translating evidence into real-world public health practice and policy. Across decades of scholarship, leadership, and training, Dr. Brownson has made enormous contributions to the field. I feel like I'm talking to a superstar, just so everyone knows that's listening. He has authored and edited landmark books, published hundreds of articles, and helped train thousands of public health practitioners. What makes his work especially influential is that it does not stop at theory. It asks how evidence can actually be used by real people in real systems under real constraints. His work has also pushed the field to think more deeply about policy, dissemination, and equity, and about what it really takes for public health evidence to make a meaningful difference in communities. Thank you so much for being here.
Thank you. Thanks for asking me.
You've spent much of your career helping define and advance evidence-based public health. When you look back, what do you think we got right from the get-go?
Well, it's interesting. I started my career working in a state public health agency here in the US. And so I then moved to academia. And so I'll think about sort of working in day-to-day public health practice first. I think this was in the 90s, and we started to realize that evidence synthesis, things like the Cochrane collaboration in the US, the Community Guide, were critical for public health practitioners so they know it works. And so I think we got that right. We started some big efforts on working on that in sort of the mid 90s, and that has continued collaborating with people all over the globe on this. I think we also got the need that most people working in public health practice trying to do evidence-based public health are unlikely to have formal training in public health. Most people working in a public health agency in the US do not have formal training or degree. So we needed to invest in capacity building. We need to make sure that the workforce we have is got ongoing workforce development activities going on. And then I think the other thing we've done well for many decades was to build surveillance capacity, to have the systems in place that will allow us to know whether we're making progress or not. And that applies often to the whole population, but also populations experiencing inequities or disparities in health. And I think that we mostly got right. The surveillance systems are sometimes hard to fund and keep going, but I think most of that we got right early on.
So what did we underestimate or what did we get wrong from the beginning?
Yeah, it's a great question. I've thought about this a little bit. I think one thing was how much the workforce turns over. So you've got a constant turnover in the workforce, and this training needs to happen, and the sort of culture of using evidence-based practice, that can be a real challenge. And we probably underestimated that. I think I didn't realize what I called the inertia effect, that we're doing things in an agency because this is how we've always done them. And that's not always the right way to do them. And so how to overcome that inertia effect, I think, is something we didn't know. I think the way we fund public health in the United States, especially in many parts of the world, probably Israel included, is very siloed. So we have a cancer program, an immunization program, a diabetes program, and those silos are often working with the same populations and the same underlying determinants of health. And I think we underestimated how hard it is to break down the silos and to move that forward. And so I think those are a few things that, at least my experience, sort of bridging the practice of public health with academic public health, where I've spent now most of my career, were things that we probably underestimated and need to remain constantly vigilant in trying to address.
So in our center, right, it's the Israel Policy Engagement and Implementation Science Center. And we're always, grappling between evidence to practice and evidence to policy. And your work sits a lot at that intersection. Do you think there's a big difference between getting evidence into practice versus evidence into policy?
I think there are some pretty important differences. And I think I often say that evidence is in the eye of the beholder. You think of a practitioner, someone trained in public health or really has public health in their blood, they are motivated differently than a policymaker who might know a little bit about health. Maybe they care about health. Maybe they want their family to be healthy, but they know very little about public health and science. And so I think this intersection, you need to think first about the audience you're trying to work with. if you're working with someone in a practice setting, how do you communicate with them? How do you think about that audience? What motivates them compared to a policymaker? A typical practitioner might be measured about, does health in my community improve? Politician might look at something like, will doing this help me get reelected? And so there are different motivations underlying, and I think finding that common ground. And I think also, public health has always been politicized, but it shouldn't be partisan. And so there's always going to be politics as part of public health because public health involves policy change. But it doesn't mean it needs to be politicized in a way that is now, where you've got one team against the other team and they're sort of fighting and missing the point about the bigger issue we're trying to solve.
Yeah, I know someone who's a player in the international world, and she would always say, in these international sessions, Israel can sit near Iran because of the eyes. And it was always the discussions was health above all. Like the politics should not
Yeah.
come into play when we have these international discussions. So
Yeah. Yeah.
resonates exactly with what you're saying. Um, so you've helped train thousands, tens of thousands, I don't know, a ton
Yeah.
of practitioners in evidence-based public health over more than 2 decades. Across all of that experience, what do you think most helps people move from understanding evidence conceptually, it's important, to actually using it in their day-to-day work, to get over that inertia that you spoke about and to just consistently do it as the default?
Yeah. I think it's a really good question. We estimate we train about 4,000 practitioners through our
Wow.
evidence-based public health training, which is basically an on-the-job training for people who mostly don't have any formal training in public health practice. And it's sort of like getting your master of public health in a week, is the way I do it. Of course, it's a much lighter, not a deeper dive the way a full master's degree would be. But I think the things that I think you have to learn the basics first. You have to learn about some of the basic principles of effective public health practice and what evidence-based public health is in the first place. And then you get to sort of a critical mass of people. So if you think of a unit together working in immunization, having enough people on that team who understand evidence-based public health, what it is, why it matters, and how we do it. Having people really understand their role on a team. I often say that public health is a team sport, and if you're the only person on the team's not going to win. It's not a solo sport. It's really a team sport, and I think that's also really important. And then I think when we teach the practitioners, we try to build in. We do it in 10 modules, and I can send you the link if you'd like to show it
Yes.
to the students. We try to build in case examples in every module with their local data for things that make sense to them and the issues they're working on. So that it's not sort of an academic, abstract learning experience, but it's really learning about what they're working on, the kinds of things they face, and some of the challenges they face, and some common ways to overcome them. And I think going back to my earlier comment about the silos in public health, I think we try to get people thinking more about working in partnerships outside of health. That so much of the problems we're going to solve are not coming from public health only or healthcare, but they might be city planning, they might be zoning, they might be education sectors, schools, other sectors where people live, work, and play that are not directly in health and probably don't have health in their mission, but many have a profound effect on people's health and their health status and really their ability to be healthy in the first place.
Right. It's like we talk about health in all policies, right? Really, where you look
Right.
everywhere, it has some sort of impact on health.
Yeah.
So when you're talking about these, bigger policy pictures, so you do a lot, there's this tug of war between, individual programs and individual decision making, and you spoke about, individual motivations versus looking at, broader systems, environments, and policy determinants of health. And there's just so much effort we can invest in anything. So where do you think, we would get the biggest bang for our buck and where should we invest most of our efforts?
Yeah. Um, I would start by thinking of an ecologic framework where you're working at multiple levels. So it's probably a yes and. Yes, I want to work at the individual level, but if I do that only, you're going to not move the needle very much. And so if you think across an ecologic level where you've got the individual, kind of a one-on-one encounter with a practitioner or a clinician, you've got the organization where they work, you've got the family structure, the friends, their workplace, and then you move up to more of a community level. And then the policy level is usually what I think of sort of that outside shell of an ecologic framework. Um, we really need to work across those levels and address as many levels as you can. Sometimes you see three levels, sometimes you see seven or eight. And I think of like the outer levels, especially as the starting place for the necessary conditions to be healthy. So if you are doing individual or group advising and teaching about how to eat healthy, but you're working with someone who lives in a food desert and they have no way to get healthy food, either they can't afford it or it's not accessible. That's the outer ring of an ecologic framework. And it's a necessary condition because all the best individual training you could do is not going to make a difference if people can't have access. And usually those outside levels boil down to making the healthy choice the easy choice, increasing access, and giving everyone the opportunity to be healthy. And people want to be healthy. They don't want to be unhealthy, but sometimes we make it very hard for people to be healthy, especially when they're living in more disadvantaged settings. And so I think that kind of working across those levels and really keeping your eye on the equity issues that work on those, because there are some interventions we do when that work across ecologic frameworks, when implemented as designs, can make equity worse. And so we want to always think about, is it improving population health, but is also addressing equity at the same time, and at a minimum, not making equity worse, but ideally making equity better, improving equity.
Can you give an example of where maybe it makes equity worse?
Yeah, I mean, there's mass media campaigns for vitamin A supplementation to offset neural tube defects. And those media campaigns tended to reach middle and upper income populations who improved the intake of vitamin A containing products, and then actually made the distance between the most affluent and least affluent less healthy. Another good example is a lot of the work we've done around the built environment, where you're trying to build walkable, movable cities better, or neighborhoods that are more accessible for walking and biking. But what happens sometimes with those is the gentrification effect, where the prices go up and the communities get more walkable and bikeable, but the cost goes up so that people who live there originally can no longer afford to live there. And so an inadvertent effect of those kinds of
Sure.
changes to the built environment can be those that actually make the equity issues worse. So it's always keeping the eye on that and sort of centering equity from the start, and keeping in mind that, it's kind of the medical adage of do no harm, and trying to at least do no harm, but ideally make uh, the conditions better for everyone.
All right. So I want to pivot for a minute to theories, models, and frameworks. So you conducted one of the first reviews on models and frameworks within dissemination and implementation science. This was close to a decade ago. And back then there were 61, and I think since then there have just been probably just as many produced each and every year. Trish Green, all we know, has that incredible quote, which I'm going to misquote now, but theories are like toothbrushes. No one wants to use anyone else's, and everyone has their own.
Yeah.
And it's always a discussion I have with my students, because part of the PhD process is to contribute or develop or modify in some way, shape, or form, right? A theory, model, or framework. And it's this constant, well, don't we have enough already? But maybe we need to build more. So, how do you address that with your trainees and your students?
Yeah. You know, there probably are double the amount now that there were when we did the review, probably 115 to 120 now, a decade plus later. Um, I think for most interventions, most health-related studies, one does not need to create a new theory, model, and framework. You might need to adapt one. So, for example, the last 4 or 5 years, especially, more and more they'll look at a framework like the REAIM framework or EPIS, and adapt it for equity issues or adapt it for a new population. Um, so mostly I would say there's no need to invent new frameworks. There's some in our review that were cited very little that had barely been used. There are probably four or five major theories, models, and frameworks that tend to overlap a lot anyway with the constructs. And so usually you can find one of those. And there's advantages to using something that other people are using because the measures are going to be better developed. There's support for them. There's more studies published about how it might be applied in a way or in a different way than the way you're thinking of it. The only times I think it might be useful is when you're studying, let's say you're studying policy change. And there are a lot of like Kingdon's model, for example, of the problem, the policy and the politics of it, and the windows opening and closing. That's not used a lot in public health and healthcare, but it could be very useful for someone who's really studying sort of macro level policy. So there are times when you want to pull in sort of a non-traditional framework, but for the most part, it's like don't reinvent the wheel. Look at one of the wheels that's already out there and see if it's going to work for, for the car you're building. And I think that usually will apply. And there's also probably some differences if you're working in low income countries about what the context for using those models looks like, but it usually doesn't mean you need to come up with a new one.
Right. Okay. That's all right. We talk about that a lot, modify
Yeah.
it, but we don't need to or combine or amalgamate other ones, but we don't need to start from scratch, which is great.
Yeah.
Okay, so we always like to end with some, advice to our students. So many of our students and our early career researchers want their work to influence policy, but they don't even know where to start. What practical advice would you give them about how to engage decision makers without oversimplifying the science?
Yeah. So a couple things I would think about. First, as a framing, I would think about, are you interested in big P policy, sort of legislative, governmental level policy, or small p policy, things that go on in organizations, including the private sector? Because those are going to look a little bit differently, and ideally do both. And so I like to have people think about that as a context. And then the other important one is where every person sits on what I call the advocacy continuum. So, for example, at the most basic level, if you live in a democratic society, you vote and you make sure you vote and you make sure you turn out to help the candidates that you think will be the best for public health, for example. On the far end would be maybe you want to run for office. Maybe you decide you really want to get in the policy fray. And then there's a whole bunch of stuff in the middle, and everybody should be on that continuum somewhere. Someone might be doing evaluation of policies and then handing that evaluation to an advocacy group. So they do the advocacy, but you're working a little bit more behind the scenes. Others might write an opinion piece or a blog about a policy issue. Another might organize a campaign for a candidate they know and care about who might be supportive of the issues that you care about. And then on the other side is that sort of running for office, being actively involved, giving testimony. And I think for most people, the further you move toward that real advocacy side, people tend to get less comfortable with it because it's just different. And so try it out and try to find your place on that advocacy continuum so that you have an impact on policy in a way that it fits with your time, your values, what you're comfortable doing, but also push yourself a little bit out of your comfort zone when you're working across those. Some of the issues that I mentioned earlier, like the eye of the beholder, is when you're working actively, think about the audience segmentation of how a policymaker might respond and how they're going to see the world differently than you do. We do this survey. I teach a policy course, and we have a survey about political ideology. And as you might imagine, the people in my course have a drastically different political ideology than your typical legislator would have. And so don't expect they're going to look at the world the way you look at it, but try to think about what's going to motivate them to make a policy change that might be different. As long as you get to the end point and you're acting in an ethical way, then that's okay. We're getting to the end point differently. A very conservative policymaker might care a lot more about fiscal outcomes from a policy than they would about changing social determinants of health because if they want to do things that will save money for society. And so thinking about kind of what resonates with different audiences, I think can be really helpful. And the other thing, a colleague of mine years ago had a quote that I always resonated with me, and it was something like, no stories without data and no data without stories. In the policy world, stories really do carry the day many times for policymakers, but make sure that your story is backed up by data and make sure your data is backed up by stories. And I think that's another really useful thing for people starting out and thinking about how they're going to make their way in the policy world. And also probably pushing the boundaries a little bit on where science would allow us to go. If you're too conservative about what a study says we should do, you may be waiting for years before we take action. And we're always working in evidence-based public health and policy and implementation science in the light of imperfect evidence. Evidence is never going to be perfect, but when it's good enough to take action, that's where policy can kick in.
I love it. So much of what you said resonates with a lot of the work we do on communication. And I'm
Yeah,
going to end with, your comment about the no data without stories and no stories without data. So Lisa Simpson from Academy Health, I always quote her and she's like, it's not my quote, but I don't know who said it. I said, okay, but I hear this from you, right? She always
yeah,
says evidence is credible and stories are memorable, right?
yeah,
So it's such a perfect sound bite, which again, Lisa claims isn't hers, but we're going to
yeah,
attribute it to her because that's who I heard it from. But it's so true, right? To just go in with numbers and dry data, it doesn't work for anybody. Maybe it'll
yeah,
work for a scientist, but anyone beyond, the ivory tower of academia, we need to make it tangible and we need to and the stories just bring it to life.
yeah. I
So,
agree totally.
yeah.
Yeah. And especially with a political leader, stories coming from someone in their voting district. So that it's not only a story, but it's a story from someone who might help them get elected is even better. Like
Yeah.
a story from, the whole diffusion theory, opinion leaders. You want to find an opinion leader who can tell the story, and probably not the researcher going to tell the story, but someone who is going to resonate with that audience a lot.
Right. Okay. Ross, thank you so much. This was great. I feel like this was a little bit of a dream come true. Check. So thank you so much. And I look forward to continuing the discussion with you one day.
Sounds great. Thanks for inviting me to have this conversation.
Amazing.